All right, thank you, John. So next I'd like to introduce Teresa Rivera. Teresa has a number of responsibilities. She is the leader of the Utah Health Information Network. And not only does the Utah Health Information Network manage clinical data interoperability, but it has also been a longstanding clearinghouse, more in the X12 world that many of you are familiar with. So Teresa is a longstanding member of our coordinating committee and an extremely valuable one at that. So Teresa, thank you for being today's moderator, and would you introduce, when you come up, the rest of the team, please?
Yes.
Thank you.
Thank you, Jay. So it's my pleasure to be able to introduce this esteemed panel that can help us understand how we're getting ROI. So please join me up here, please. Dr. Matthew Eisenberg, who is also part of the coordinating committee. He joined Stanford Healthcare as Medical Informatics Director for Analytics and Innovation in February 2013. His work at Stanford Healthcare focuses on interoperability, specifically HIE, quality, and regulatory reporting, pop health, and analytics for improvement. That's a lot. Next, I have Stefan Perenda. With 10 years of experience in the healthcare sector, Stefan leads Clarito's data partner network development efforts to promote sustainable interoperability strategies and drive adoption of non-treatment use cases by healthcare providers, HIEs, and technology vendors. And we're one of the newest to join, so excited to hear more about that. Next, let me introduce Tara Kramer. Tara Broxton Kramer has been the executive director of the Georgia Regional Academic Community Health Information Exchange, or GRACI, since November 2011. She was previously executive director of the East Georgia Health Cooperative, a rural health network. And I'm excited to hear more about the HIE efforts there, especially during this time of disaster. I know you guys have been very helpful with that. And last but not least is Tracy Rico. She is a nursing informatics manager that is focused on improving health outcomes through interoperability and innovations. She has spent the last 3 years developing and implementing the first clinical interoperability strategy for Superior Health Plan. So please help me welcome this esteemed panel. And Matt, I think you're going to take us first through an introduction of your work.
Thank you. How do we do the slides? On
Green button.
green button. Great. Green button. Fantastic. Wonderful. Today's agenda, we talked about that. Well, thanks. I'm Matt Eisenberg. I tend to have spilkies. It's a Yiddish term for moving, so I'll try to stay at the mic if you haven't heard about spilkies. I'm going to take a second to just thank John Kansky, who I love working with. He's here all week, try the veal, and he's really a delight. And I actually also, Jen Rosa, would you just stand up? Because the coordinating committee doesn't exist without Jen. Okay, so let's see. A little bit about me and Stanford Healthcare. So we'll start a little bit about that. So I work for Stanford Healthcare. Our main site and campus, main hospital, is on the Stanford University campus. Who has not been to Stanford University? Come visit. It's a beautiful place. But we're actually a pretty big network, so that on the upper right you'll see our network. The beautiful 1959 facility down to our left is actually our current main hospital. It's no longer actually California standard for earthquakes, and that's actually our newest, our second hospital. That's a Valley Care Health System out in Pleasanton, in the Tri-Valley area, which is known mostly for wine and not for healthcare. But we're a small two-hospital system, but we have a large ambulatory practice, almost 2 million visits a year, but a small two-hospital system. We are growing. So cool slides. The new buildings look a little different than that 1959 building. This is our cancer center in the South Bay. It's located in Los Gatos and San Jose. That's our main ambulatory facility just north of the Stanford University campus in Redwood City. That's a new building in Emeryville, right near Oakland and Berkeley. And that's going to be the new hospital for Stanford, opening up this coming November, and we hope it's going to be a beautiful facility. So Stanford Healthcare is an academic medical center. We're part of Stanford Medicine. It's a three-legged stool that includes our system, the Children's Health System, as well as the School of Medicine. We have a three-legged mission, care delivery, discovery and translational discovery, and education, all three. And I think you'll see as we talk about the eHealth Exchange, that's part of where we are and where we've gone. So let's see, what else do I want to talk about? So Stanford Healthcare. Our goals for for Health Information Exchange in general are outlined here. Basically, we really want records to be available at every touch point when a patient is seen or evaluated or cared for anywhere in our system. Clinic, ED, hospital, in-between visits, the whole shebang. We've really worked hard to educate our patients about the value of health information exchange, because initially people were just scared and all they saw was, breach, 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 I don't want to do this. So we actually put together a lot of educational materials and worked with our HAM department, and then Stanford Healthcare moved to a default opt-in model with an option to opt out if patients wanted to. But if they did, we wanted to make sure they understood what the ramifications was for that. And we had to do that in order to participate in the eHealth Exchange. We were going to leverage standards-based exchange. That was sort of a given. And we needed to be integrated into our workflow. It had to be in our electronic health record. We had already been doing HIE through we're an Epic shop, and we had been doing HIE through that. And our clinicians were well aware of it and starting to use it, and we wanted to build on that. We wanted it in their regular clinical workflows. We really wanted to partner first regionally, but then nationally, and then we really wanted to see if we could lead in the space. So, I'm going to try and boil this down. And Margaret, where's Margaret Donahue? So the 3 V's of our connectivity strategy, which for us led to the VA. But vicinity, volume, and value. The Palo Alto VA is 2 miles from our hospital. We're a major provider for radiation oncology for veterans in the community. Menlo Park, 1.5 miles from our hospital, has a large outpatient VA facility, the San Francisco VA facility. A lot of the VA physicians are on our faculty. They participate in research with us. We wanted to get connected to the VA. That was our first driver. Other vicinity areas were just to our north is Dignity Health System, a large health system that was on the eHealth Exchange. We share a ton of patients. That's the volume piece, a lot of crossover. We wanted those records, a lot of patient share. And then the value piece. We wanted to make sure that we had access to the information where we wanted to, and we wanted to actually leverage those strategic relationships that we had to start with. So we went live on the eHealth Exchange after a very brief case of what I've described previously here as DERSitis. DERSA, Data Use Reciprocal Service Agreement. We spent a lot of time with our compliance offices getting them over a brief case of DERSitis. We actually wrote a white paper to try to discuss the difference between breach of data in transit versus HIPAA breach, and had hours and hours of discussion. So the foundational was default opt-in. We wanted that to be available, and then we went through our problems with DERSitis, and once we got over that, we joined the eHealth Exchange. We implemented direct messaging as part of what was meaningful use. I'm going to be struck down because you can't use that term anymore, I guess, or you shouldn't. It's promoting interoperability. Joined a HISP, and then our first connection was the VA. So that's where we started, and that's where we ended up. And then the SSA came around, and we thought, oh, this would be great. And I'll just tell you, Marty's here. I'm a big proponent. We'll talk about our data, but it was really helpful for us. And actually what was really helpful for us to learn about how to do this was it actually required us to figure out who we were from a facility perspective. And in the HIE world, if you don't know who you are in your facilities, it's really hard to do that. So that was really very helpful. Dignity, we connected very quickly, and we have a very, very robust, you'll see they're our 5th largest health information exchange partner across all of our partners, and we connect with everybody, 50 states, 3,000 people, 3,000 organizations. 5th, and they're non-EHR-like. They don't run Epic, but we can exchange outside of encounters. Anything we can do with an Epic shop, we can do pretty much with a Dignity shop, and sometimes more, which is really kind of cool. We joined Care Equality in April of 26, and we were early adopters with AssureScripts and RLRS. So once I show you these slides, I'm going to have to kill you, but basically when I log into my EHR, this is what I see. We track metrics. We track how many records go in and out, and it's better to give than receive. That's our motto. We actually look at what's actually been visualized, what's been viewed, and we actually look at what's been viewed as a percentage of encounters. And as you can see in our inpatient ED space, we actually look at a lot of records. We actually look at records. And then this is our list of who we exchange with that's not in our same EHR platform. Dignity's number one. That's 5 million records sent, 284,000 records received. It's a huge system. A record locator service, 2.3 million. We have 2 large HIEs that we're involved with. I should mention that, Santa Cruz, but more importantly, San Diego. Stanford Healthcare has a unique relationship with Qualcomm. We provide physician services. We actually are the employer-based services for Qualcomm. They're located in San Diego, so we wanted access to the San Diego Health Connect. So that was another real driver for us in terms of value and vicinity. And then you'll see Athena's on there, the VA's on there, and SSA, 11,217 since we started. We do about 350 a month, almost 400 a month now, and we keep growing. So that's been our experience. We still have challenges, the 3 R's, relevance, reconciliation, readability, usability. These are, okay, we can talk about this all day long. You have the same problems. Clinicians need to make sure that what they're getting is actually, relevant to what they're actually taking care of the patient for. Sometimes it isn't. Reconciliation is a nightmare. Lots of different models. EHRs typically send sort of encounter-based because they're encounter-based systems. HIEs send patient-level aggregators. Totally different. We're trying to go back and forth, and we're learning that. And usability, readability. So I'm just going to leave you with a couple of quotes from a really wonderful article. The lead author is J.B. Perlin from the National Academy of Medicine. That I think is really helpful. Creating a longitudinal, complete, and timely record of information for each person has arguably been the most important goal of federal HIT policy and continues to have top priority. That's why we're here. That's why we're doing this. And the ultimate goal is to develop a learning health system. So that's my scoop for Stanford. Who's next?
Hey everyone, my name is Stefan Harinda. I'm with a company called Claretto. We actually have our foundation in Med Virginia Health Information Exchange, have been around since the early 2000s, participated in eHealth Exchange since 2009, and I think we're the first HIE onboarded with the SSA for their disability determination program. Today I'm going to talk to you about a pretty logical extension of that SSA use case, and this is basically taking that model of authorized electronic release of information to commercial insurance markets, and specifically life and disability insurance. Not talking about health plans, that's a separate issue. So a quick background on what's going on in the life insurance market and what has been going on for the past few decades. Today there's about 60 million households in the United States that are underinsured with an average mortality protection gap of about $200,000, 38 million households completely uninsured. And you can see the general downward trend dating back to 1960 in life insurance ownership rates, with a specific drop-off right around the time of the financial recession that hasn't really recovered. And I'm sure everyone here is thinking it's those millennials again, and it's actually, there's some more deeply rooted issues here. On the distribution side, most people, I'm sure even most of us in this room would have problems identifying what type of life insurance coverage should I get? How much coverage do I really need for my family? And how much is it going to cost me? There's some real information asymmetries there and kind of a difficult buying process. And then on the operational side, the underwriting process is really painful. How many people in the room have purchased life insurance and been through underwriting? Yeah. And how many enjoyed it? And what this all leads to is people just don't buy insurance coverage the way they should be doing. So according to Swiss Re, which is the largest reinsurer in the country, in the US there's a 25 trillion with a T mortality protection gap. Not all those dollars would be available to us as healthcare providers and health information exchanges, but there is a sizable need in the market. And if we look what's happened over the past few years, a couple trends on the distribution or sales side of things in life insurance, that market's getting disrupted. I don't like using that term. I use it, less as a buzzword and really more about what goes on in in venture capital markets. So what you see is in the first 6 months of 2018, there was over $60 million that VCs plowed into essentially the same business idea, just selling life insurance online in different ways. On the underwriting side, all of the momentum and focus has really shifted to electronic medical records and when and if and how those could be available to help them meet their underwriting needs. And I think if you see another industry starting to write white papers about your own industry's health IT systems, it's probably a pretty good indication that there's some very real interest there. So how did we make this jump from a longtime SSA participant to starting to work with life insurers? Just top and bottom here are kind of two really simple schematic diagrams. You'll notice kind of what's common between the top and the bottom is that all of this is founded on having a signed patient authorization that's HIPAA compliant in hand directly from a patient saying, hey, I authorize the release of all my health information to a designated recipient. And the eHealth exchange thread is common as well. When really the only difference is here when we're working with life insurers is that instead of SSA always being the requested organization, it could be one of many life and disability insurance companies out in the market. And those are the names we all know well: New York Life, Pacific Life, Northwestern Mutual, Mass Mutual, those types of organizations. We really manage them as kind of a network and do business as Claretto here. We actually established a separate organization ID on eHealth Exchange so that for parties where we're connected for both treatment and for this life insurance use case, they can differentiate and say, okay, this request is from Med Virginia. I'm going to treat that one way for treatment purposes. This request comes from Claretto. I might have a different set of business rules that I can apply based on that organization ID. And at Med Virginia, a lot of this was driven around financial sustainability. So SSA has been and continues to be a great use case for us. They published, I hope that Marty doesn't mind me pilfering some of his slideware here. But they've really proven out, hey, you can actually make more money by transitioning to electronic. You'll actually see an increase in your transaction volume because you become kind of a preferred partner. You'll see a decrease in release of information costs, so no more paperwork, a lot less manual time to process requests and so on. Then of course SSA has the added benefit of a reduction in uncompensated care and uncompensated care cost recovery. And you can see some of those impacts in those graphs on the right, both pre and post going live with SSA. For life insurance, it's really the same story. You get that transaction revenue. You can actually see an increase in volume relative to what you might get today, and a reduction in those release of information costs. No more manual workflows or paperwork. What I did right here is just a really simple crosswalk to kind of demonstrate that just because a use case is not treatment doesn't mean that it can't be aligned with the missions of all the organizations in this room. So if you look on the left, we've got some common benefits of interoperability. Reduced paperwork, of course, that's something SSA has really blazed the trail on. Eliminating redundant and unnecessary testing. A common part of the life insurance underwriting process is that people have to get paramedical exams done. A paramedic actually has to come to your house. They typically take blood and urine samples, send those off to Quest and LabCorp. If you have a lot of electronic data available first, we can check to see, do we actually need to do a paramed exam here? So you can actually reduce lab testing rates. And then around consumer healthcare engagement and reducing overall healthcare costs, life insurers are starting to get really innovative in terms of how they engage their clients and transition from just underwriting risk up front to really managing a portfolio of risk longitudinally. John Hancock has a program called Vitality that takes into account a lot of consumer engagement strategies, wellness programs, Fitbits, all those types of things. And of course, there are benefits for their policyholders if they participate. And life insurers are really uniquely positioned. They have very long-term relationships with their clients. It's not like a health plan where people may drop out after a year or two. This is a 10, 20, potentially 30-year relationship that they have. And they're getting more engaged in really promoting wellness. John Hancock's program even had some data around 30% reduction in hospitalization costs for their Vitality members versus their non-Vitality members, longer lifespans, and so on. I'm not sure if all those were randomly controlled, but the data is pretty interesting. One of the common misconceptions here is this really once we say, yes, this is in line with our mission, something we should potentially consider doing, is there a sufficient opportunity here? And for a lot of healthcare provider organizations, we often hear, well, we don't really see too many of these requests today, and the answer to that is really you shouldn't be seeing that many requests. Life insurers really don't request medical records on the vast majority of their cases. It's probably around 25% industry-wide. Some companies might be as high as 40 or 50%, but we've worked with companies in our pilots that have done less than 15% of their cases that they get medical records on. There's really a downward pressure on medical record utilization. It's expensive to get access to people's records, and it takes a really long time to do so. And traditional underwriting, which is really based on age and amount guidelines, so they say, hey, you're between 40 and 50 years old, looking to purchase $500,000 of coverage. Here are the things we're going to do to underwrite your case. And in those protocols, they've prioritized paramed exams, lab testing, some of these other things that are really invasive and time-consuming for consumers. You've also seen a shift now. There's a lot more adoption of simplified issue and accelerated underwriting programs. Life insurers do have access to a growing amount of electronic data. None of it's really a perfect replacement for medical records. They get prescription drug claims from the PBMs. They're starting to get medical claims data from health plans, and they're getting historical lab test results electronically from companies like Quest and LabCorp. So they'll push to using those simplified issue and accelerating types of programs if they can't push somebody through the traditional process. In terms of volume, just a quick comparison on the left, SSA has 2017 2.2 million disabled worker applications. There's about 11 million individual life insurance policies that are issued annually, but industry estimates are that life insurance applications might be as high as 20 million cases per year. And that doesn't include things like underwriting claims, other business processes for things like disability insurance, long-term care coverage, and other non-major medical types of insurance policies. And once we get into the process of having a conversation with other organizations about participating in this use case, there's typically this kind of dichotomy between what are their requirements going to be in order to participate or to believe in participating, and what is the life insurance market looking for in terms of solutions. And we don't think that those have to be mutually exclusive. So of course, what has to be true first for a health information exchange or a provider network to participate? Of course, trust is number one. Number two, a lot of common ground between the two of us, and we kind of look to eHealth Exchange for that, so we're speaking the same language from a technical, legal, governance, security perspective. We do offer a few different implementation options. We've found that that's really necessary because not all technology vendors support something like the SSA access consent policy, and so we, for handling those authorization documents, have developed some workarounds for that. If everyone's familiar with the 5 rights of medication administration, we've kind of developed, at least from our own systems design perspective, the 4 rights of authorized electronic release of information. So, is this the right patient, the right authorization? Are we sending the right record, and is that record going to the right place? We really make sure that no data is persisted or used for the wrong purpose. So we have an individual's consent for one reason. We use the data for that one purpose, and then we're purging that from our systems. As a federated HIE, that's something we've been doing for a long time. We don't store or aggregate other people's data, and so we were set up really well for this use case. And then of course it's that, hey, if there's an insurance user interacting with the system, are there going to be some special rules applied to them? And do you provide a safety net? So are you monitoring things appropriately to make sure that was an authorization always sent? Was it the right authorization? Those types of things where we can kind of put a safety net under all of this and figure out better ways to police things. On the life insurance side then, we're looking at, life insurers, just like clinical users, they want a simple workflow. They want to make sure that, hey, if I query for a patient, is that person likely to be there? All the things that physicians want are really similar to what life insurers want from this process as well. And again, we think we can have, kind of everyone can have their cake and eat it too with this. So how do we position this use case for success? One thing that might come to mind immediately is, well, let's use the electronic health data and the data accessed over eHealth Exchange as a simple replacement for medical records. So we know from a content perspective that's not always possible. And so what we really want to do is position electronic health data as a way to bridge the gap on the underwriting continuum. If you think about what tools life insurers have access to today, they have electronic data, but it's typically not really very clinically comprehensive. You have some prescription drug claims, motor vehicle reports, credit score data from like Experian, those types of things. Not really a replacement for health information. Whereas on the left here, traditional underwriting requirements as paramed exams, those lab tests, those are expensive, time-consuming, and so on. So putting electronic health data right in the middle can act as a triage tool in the underwriting process to say, what do I know today about this person, and then what of my other tools do I need to use to complete this case? In lieu of having something to fill that gap, consumers are really kind of stuck in the middle here. So on the one hand, consumers can go through the traditional underwriting process. It's inconvenient for them. It's very invasive. It's expensive for the life insurer. On the other hand, consumers can kind of migrate to the right here and say, hey, just use whatever electronic data you can to give me my policy as quickly as possible. In those cases, consumers are actually saddled with higher premiums because less is known about their overall medical risk. And there are limited coverage options. You can't buy as much coverage. Policies might cap out at a couple $100,000. And there may be only certain types of products that are available through those simplified issue programs. So, we've been out in the market for a couple of years, and as we've gotten health information exchanges and provider organizations to sign up and had conversations with a really, really large number of organizations, there's a few things that we've learned here. So part of this is, if you're looking at participating, really make sure that you understand the life insurance side as well. It's important to present a solution that, kind of like SSA, gives life insurers as the customers really exactly what they're looking for. If they have an even more complex process to access data electronically, they're probably going to stick with the current paper records. Rising tide lifts all boats. Most life insurers do business nationally. You're talking about big national companies. They operate in all 50 states. And they, of course, want to see that, hey, if something new comes on the market, that there's going to be a path to national coverage. If you're still pretty early in this process and looking at things like SSA, it's important as you're working through data governance approvals, policy changes, any technology things, to kind of stack use cases on top of one another to say, if we do this, we can access SSA, we can access life insurance. We have all these other things that we can kind of add to the queue. And I think at the end of the day here, cross-pollination is super important. I think our team, we've been really fortunate. We have a technical team with a few people. Those are longtime Med Virginia veterans. So they've all been with our organization, experienced in HIE for 5+ years. Whereas our CEO comes from the life insurance side and has designed an automated underwriting system that's underwritten over 3 million policies to date. So it's really a great combination and a lot of learnings from both sides.
Hi. I won't touch that. I can speak pretty loud. Quick disclaimer before I get started. I had a very sick child last week, so the slides are not totally up to date, but I will update you as I go. Fair? Fair. Okay. So Gracie is what we refer to in Georgia as a regional health information exchange, meaning we are not the state designated entity. We are not bound by a region. That's just what they call us. We roll with it. So we were founded by originally three healthcare organizations in the state of Georgia. Navicent Healthcare, AU Health System, and Emory. Through the years, Emory decided that they were going to create their own clinically integrated network, HIE, so we were not left with, like we got leftovers, but Navicent Health and AU Health, who have been great, strong partners for us through the years. So they started working together in about 2009, 2010, and in 2013, another regional HIE in the state decided, our focus really is on working with our county on indigent care. We don't want to run an HIE. How about if you take over the operations of our HIE? So we have three primary stakeholders, Navicent, AU Health, and Chatham County Safety Net Planning Council. So those organizations make up our board. We have a 7-person board. We're our own 501c3 independent entity. So after the two healthcare organizations stood us up, they shoved us out of the net, and we continue our best to fly. So our founding purpose has always been and continues to be around care coordination. And as we plan our HIE and as we grow, we always come back to the doctor is in front of a patient. What information do they need to make the best decisions? And as the patient flows from care setting to care setting, as they age, how can we help them? How can we make the data flow? So that's remained our core focus. And you'll see that makes us a little different from where a lot of HIEs in the industry have gone. We hope to continue to grow. Clinical integration and affiliation has certainly become a large part of what we do. It's a part of the how people are paid now, right? It's how people are surviving. So how do we survive in that world? And it turns out if you can play in the care coordination space, you also are very helpful for clinical integration and affiliations. And then building a community record. We are a data repository. We're a centralized HIE. So for care coordination, nothing that you all don't already know. Primary care sends a patient to a specialty provider. They want the information back. The specialty provider also wants to know what the primary care doctor said about them. So we see a lot of our providers using a combination of direct and the HIE. They're using direct for the referral. Hey, Dr. B, I'm sending a patient to you for this reason. Check Gracie for the medical record. So we have a lot of that happening. We are located, our HIE is actually located in a rural area. So we work with a lot of rural hospitals that are transporting and transferring patients to large tertiary care centers. So a big use case for us as well. And ED visits. I always tell doctors that Gracie or any HIE is a great introduction to a patient you've never met before. Meaningful use and payment reform is certainly something we have to be very aware of, or promoting interoperability. Clinical integration and affiliation. And one benefit that was unrealized to us in the very beginning, but has really become a forefront of what we've done lately, is around planned and unplanned downtime. So we've had several hospitals that were doing rip and replaces or flipping from self-hosted to cloud-hosted. And so we were able to set up web portal accounts for all of the providers on duty for that 15 hours or whatever the time period was. And instead of using a backup EMR, they were using the community record as the record during that period of time. So we encourage all of our organizations not only to put Gracie in their change management procedures, but think of HIE in that perspective as well. So Gracie is, we say that we share beyond the standard, and in this vendor-driven world of CCDs and CCDAs that are a standard, we ask for more than that. Because we are driven by care coordination, the doctors want notes. The doctors want documentation. And so every build that we do, whether it's a one-doc practice or a large healthcare system, when we talk to the vendor, we ask for data elements, and we say, how can you send them to us? So that we are, if we're getting ADTs and ORUs and however you can send it to us, we do our best to receive it because that's what the doctor wants to see. So we do share a little bit out of the standard, again, focused on care coordination. Surprisingly, we're able, especially from hospitals, we're able to get a lot of documentation, and more of the ambulatory EMRs are able to send them to us as well. So that's a growing area. Again, we are dependent on what the EMR can send, but we are big proponents of always asking for what you want. So I said that we are regional. HIE is what we're called. We're not really regional. As you can see, we are all over the state of Georgia. These are not per site markers, it's just geographic markers. But we really, I think, we're really proud of the growth that we've been able to accomplish. So we have 50 plus data contributors. 50 plus means 50 pipes. So one health system that might have 5 hospitals, it's just one pipe. So 50 is a low number, but those are the pipes we're managing. We're over 250 locations now. 3,900 active providers. Those are providers that average 1 query per day. So these are truly active users, and not just somebody that clicked the button by accident, because that happens. And we have patients in our system that have data that has been contributed on them from up to 11 different data sources. So as a provider, when you are able to get a really clear picture of the patient and data from multiple places, that's the golden goose there. So again, 50 plus data contributors. We really have expanded, again, care coordination. So hospitals, physician practices, we've integrated behavioral health. So in Georgia, we have community service boards. They are independent organizations that contract with the state to provide behavioral health services for the Medicaid population. There are 12 of those organizations in the state of Georgia. We have integrated with 8 of them. The others are coming in. So we have found a way to work with behavioral health. We're sharing limited data sets today, because you all know how fun those regulations are. And we hope to expand that. We're testing some ways that we can expand that moving forward. Correctional health, that's been a really fun and interesting project for us. We're writing some papers on that now to hope to share that best practice and spread through our state. So we had a county jail in our network area that had 3 deaths in 18 months. 2 of them were because of undisclosed medical conditions at the time of booking. So diabetic, they think he's drunk, he goes into holding, and bad things can happen. So what we've been able to do at the jail is not only work with the medical clinic provider to set up an electronic medical record that's connected to Gracie, but we also have integrated into the booking system. So along with getting fingerprinted, they are querying our HIE to see if there's a pre-existing medical condition on the patient. So that's been really interesting. I've learned all kinds of fun things about a jail. And when you work with the jail, they like to make you tour it every time, and going through the Sally Port and the whole 9 yards. So I know the lingo now, and it's really interesting. If you ever have an opportunity to do that, I would advise you. They are a very active user. On the flip side, the hospital in that area is getting folks who are arriving off their meds. They're able to see what the medication regimen was while they were in jail, restabilize them, and get them to be seen by an FQHC or another safety net provider. So really beneficial for both the jail and the community. Home health is another area that we've expanded into, and care coordinators. So we've had a couple of our large hospitals contract with a third party to do their care coordination and care management. And so we are integrating with those companies. So not only are they querying the HIE to see what happened in the hospital and to follow the patient's care, but they're sending us their summary of care documents as they're documenting as well. So kind of a new area for us. We are now at 23 different EMR platforms that we have integrated with. And I'm not counting, Allscripts has 3 different versions. I just mean Allscripts in general. So Allscripts would be one. So 23 different. We pride ourselves on being vendor agnostic. And so far, we've been able to prove that. I can't see that little one down there. Okay. So I said that we are a centralized repository, and we are, but we do have several what we refer to as external partners, so we have federated connections as well. Most of those come through the eHealth Exchange. That's how we've leveraged our partnership and being a participant with eHealth Exchange. The first out of the gate for us was the VA. Really, honestly, was why we joined eHealth Exchange. I'm sure many of us can say that. So Georgia has a very high veterans population and the most military bases of any other state. So VA and DOD, we needed that information. One of our primary partners, Augusta University Health System, shares a bridge and a ER with their VA, Charlie Norwood in Augusta, Georgia. So that was one we had to do. They're also a medical college, and their students do residency at Eisenhower, which is on Fort Gordon. So very important for us to have that connection. So we were able to get those stood up, thankfully, through the eHealth Exchange. The eHealth Exchange DRSA for us has also been very beneficial. I'm sure that everyone in this room except for us could say that your legal departments are quick and efficient, ask no questions. It's just, so having that agreement, the DRSA already in place, and you can just jump straight to work, has been incredibly beneficial. We work with Palmetto Health System in South Carolina. That was not through eHealth Exchange, but because we have such a large concentration in Augusta, Georgia, Palmetto Health is only an hour away. And so there's a large population between Augusta and Columbia that go to both places. So that was advantageous for us, and that was our first really crossing the state lines. Adventist Health System, Emory Healthcare, see, we did get Emory ultimately. No, it's federated, great partner for us. We're also connected to our state designated entity. We get immunization information, we get a CCD based on Medicaid claims data through that connection, and Patient Bridge in Alabama. So I said it wasn't up to date. So if you all remember a couple of weeks ago, we had Hurricane Florence, quickly followed by Hurricane Michael. And last year, we had Hurricane Irma. So Gracie was very busy with those three hurricanes. What we found with Hurricane Irma, which was almost a year to the date from Florence, I don't know if anybody knew that, was that when people left Florida, when they were evacuating, a lot of them landed in Atlanta. Seems to be a good destination point. So we were watching it, and we knew that folks were going to be coming north, and how could we help? We reached out to eHealth Exchange and said, hey, who's in Florida? Who can we stand up a quick connection to? What are some contact names? So we were able in 24 hours to stand up 9 eHealth connections during Hurricane Irma, the 24 hours before the hurricane hit. Within a week after Hurricane Irma, from those 9 connections, we located information on 763 patients. So we knew we did the right thing. But how do we plan for this in the future? And then life happens, and then Hurricane Florence came. So we quickly contacted North Carolina, South Carolina, Alabama, all the folks that we thought patients may be moving to. And we were able to, again, stand up connections within 48 hours. So we stood up emergency connections with Atrium Healthcare. You guys are here. We stood up emergency health connections with the North Carolina Health Information Exchange, with Alabama, Tennessee. We tried with Med Virginia, and we're still, we weren't fast enough. It was my team's fault. But we've got it working now so that when things come in the future. And again, we've kept those up because Michael came right behind us. So for us, the power of eHealth Exchange really is that DRSA, being able to stand up connections when you need to without having to agree on a rule set. So we're expanding. We're the first in our state to integrate behavioral health, and our work with the Chatham County Jail actually got us not only a nomination with the Milbank Award, but we were in the top 3 finalists. We didn't get the final award, but we were at Datapalooza and got to stand on the stage and all that fun stuff. So interoperability for us is key. Where do we go in the future? We really are a query-based HIE. We are not doing anything much fancier than that. But what we focus on is when the doctor clicks the button, that he sees information. We audit our data. We manually work our MPI. Some of you are going to fall out of your chair. But it was important for us that when the doctor clicked the button, that he got information on the patient, and it wasn't hieroglyphics, that it was real information he was looking at. Why do we manually work our MPI? Because we are in Georgia, and everybody has a junior and a third and a fourth and a fifth. My son is a third. I'm talking about myself. We also, we ran across 4 twin sets in the very early days that we have kept as test patients. And whenever we come across an MPI algorithm, we run those twins, and we run thirds and fourths and fifths. And we haven't found one that passed the muster for us. So Michaela and Michaela have been gold for us. And keep us manually working our MPI. So we get about 1,500 potential duplicates a day. We're able to clear out about 1,300. We have one full-time staff member that's what she does. Yes. And so we are moving into what else can we do? Events notification, results delivery, we'll be doing that by January, we think. And then what is our role in ACOs and CINs and population health? People are competitors. They don't want you sending their data, but they want all the data, right? So what is our role to play in that? In some cases, it's just going to be a provider of data. Other folks, the smaller institutions, are leaning on us to say, what kind of pop health tool can you stand up that we can all use collaboratively? So we're actively having those conversations. I think we'll be in I think we'll be there by this time next year. That's our goal. That's us.
Morning. All right, I stand no chance of being able to see those, so that's teeny tiny. Okay. My name is Tracy Rico. I work with Centene and Superior Health Plan. I'm currently the manager of telehealth services, and I run all of their information exchange and interoperability projects. Centene, it helps if you click, right? Okay. So Centene is the largest Medicaid managed care organization in the country. We have 31 states. We provide Medicaid, Medicare, and then we have an ACA product or health insurance marketplace product called Ambetter. Superior is the Texas version. So each state has their own. Each of the 31 has their own. We are wholly owned subsidiaries of Centene, and since '99, we've grown into a statewide leader in healthcare. We're also the largest Medicaid MCO in Texas, and we offer 9 unique products and more than 1.2 million members. Our focus is on improving outcomes by providing quality care coordination and care management while reducing duplicative services to lower costs and improve the patient experience. That could definitely be shorter. Huh? Can I what? Oh, yeah, it's tiny. Oh, that's better, actually. Okay. So how does data save lives? Why is this important to me? I'm actually a nurse. I've been an RN for about 13 years. I did patient care for the first half or so. It's getting to be less than half now. And then I started working for Superior as a case manager, where I would work with members and connect them to resources, talk to them about their pregnancies, do case management telephonically. I quickly saw that within a couple of months it was frustrating because members had no idea what we offered, doctors had no idea what we offered, and all these nurses are trying to help people, but there's no one connecting the dots. So we would enroll them in a program, and then nothing would happen because their physicians weren't on board. So I helped build out the first clinical liaison program. They started with 3 of us. There's 13 of them now. Across the state, the job was to educate physicians on cost and quality initiatives and to let them know, what do we really offer members and how can you partner with us to make that happen? From there, part of that job became telling them a lot of the things, so taking out analytics and saying, hey, you're doing this right, you're doing this wrong, this is what you can improve in, and that's great, except if you can't offer a solution, it kind of sucks to tell people you really suck at this thing. The favorite was ERs, so I would have physicians who would have atrocious ER rates. The patients were going to the ER for everything, and so I'd have to go out and tell them, hey, you need to rein that in, what can you do to rein that in? And they're like, well, you're bringing me data that's 120 days old. How do you want me to, how is that actionable? I'm like, you're absolutely right. Anybody heard of anything better? Because I gotta wait for claims. Does someone else have something better? And I met my first HIE, and they are family now. They taught me everything I know, HIE in HIE land. So I started working with HASA, and I'll go through that in just a little bit, but the goal being, I wanted to be able to take actionable data to providers. So going from 120 days to 1 day. And then, so that along that, I became an HIE advocate, obviously, and then I worked on my master's and became a clinical informaticist centered on all things interoperability. So why did this, beyond being a nurse, what made this personal? There's a step in between there, right? So it was, I knew how to be a nurse, so I saw that point of view. I had seen what it's like to be on the doctor's end and hear their complaints about what we couldn't tell them or could tell them about a patient. And then I was missing the last piece, the member piece. So I have a really good friend that I happened to meet 2 months after he bought our Better product. So I had nothing to do with his selection, but he was one of our members. And he was complaining one day that, he's 37 years old. He's complaining that he's having palpitations a few times a year, to the point where he actually passed out a few times. He presented to ERs 3 different times. And 3 different times they took their natural model and went, you're not dying right now, so go on and hopefully follow up with somebody maybe. But that'd be where it ended, because at the time he had no insurance. So there was no PCP, there was no cardiologist, there was no case manager, and there was no MCO helping him out. So when he met me, I told him that's not okay. we're gonna work on that. I'm kind of a nurse or patient advocate too. So after 3 ER visits and a misdiagnosis and no treatment and no follow-up care, I took him to see his first PCP. I picked one on purpose that was part of the pilot program that I was running with HASA, which is the HIE in San Antonio. And that way I knew that they could pull any information out of any of those hospitalizations, because he was like, I went to this hospital and didn't have a clue how to get those records. So I made sure that we could access HIE data, and that was the first thing that I made him do. And we found that he had an EKG rhythm from an ER visit that showed that he'd had evidence of a previous heart attack. And no one told him, and no one followed up with him. And this was all a big surprise to read it all at once. So we shuffled him into a cardiologist. Cardiologist did an echo study, did the standard workup. In the echo, they found that his ejection fraction was about 10 to 15%. Normal's about 60, so his heart was squishing 10% of the time that it should, or volume that it should. So they went ahead and admitted him immediately and started him on medications, but still didn't have any reason as to why this was the case. So 27 days later, he was readmitted to the hospital because no one bothered to keep looking. And they weren't listening when we said he's still got this problem where his heart races and he passes out, that there's more to it. So I collected all of the things out of the HIE. I went and physically collected all of the medical records that didn't get contributed to an HIE, but I figured out along the way. In the first hospitalization, I had everybody print out everything that they did there, every EKG, every test, everything, and I put it in a physical notebook. And while running an HIE project, do you have any idea how gross it is to carry around a physical notebook of printed records? It was painful. So at that point, he started feeling bad again, and so 27 days later, he was readmitted to the hospital. I demanded a new cardiologist. I demanded an electrophysiologist, and I took all the paper and laid it out on a table in his room. And I was like, I know you've never met me, and you're going to think I'm crazy, and you'll either love or hate me. I don't care which, but either way, we're figuring this out. And so he went through with his calipers, and he looked at the changes over all the EKGs, and ran across. I even had some on my phone that I screenshotted, which sorry HIPAA. I had patient permission, okay? But I screenshotted a couple of them while he was complaining about an episode when no one could see it. And I handed him my phone and he went, holy cow. He has like at least 3 arrhythmias and one of them is absolutely lethal. I don't know how he's still alive. The next day he went in and they put in a defibrillator and an AICD. So it will shock him if his heart rate gets too high and it will pace him if he gets too low. So literally access to HIE data, finding those things along the way, and carrying around a god-awful paper CCD made me super passionate because it actually saved his life. I think he's stuck with me. Thank you. Yeah, I'm still vicious. By the way, if you ever get sick and you need to be in a hospital, take a nurse with you. I can't even tell you how important that is, what a difference it makes, how much better behaved everybody else gets very quickly once you tell them, by the way, I'm a payer, I'm a nurse, I know informatics and I know healthcare data, so you might want to do your jobs right. It works out much better that way. And I sound really rude saying that, but I'm not. I say it really nicely. In the end, they love me. They go, you taught us a lot by the end of this. And I'm like, yeah, I know, it's not a state complaint. Isn't that awesome? We can teach you stuff. All right, so clinical data strategy. I didn't know what I was doing when I started it. I started with that one HIE, and we started getting ADT messages, and I started a small pilot that was just 20 providers. With the one HIE, we covered 100,000 members, and we pulled ADT records, and literally, they would put them up on their portal, I would download them every day, and then break them out into a spreadsheet and send them out to providers. And to our internal case management team. That way, members got a call if they went into the ER the next day and said, hey, we saw you went in the ER. It says you presented with this. How are you doing? How can we help you? Do you want to enroll in case management? It's sent to their PCP, so their PCP knows, hey, let's get them in within this week, or let's get them in tomorrow, and let them know what their alternatives are. They don't have to go to the ER for strep throat. Really, it's cool. We can do this. So it's a big education project. In the first year, we got 9% of the what we call potentially preventable, thank you, Pop Health, potentially preventable ER visits down with those 20 PCPs by 9%. In 2017, our leadership looked at that and went, that's kind of cool. So let's look at the others. So there's 5 HIEs in Texas. We got 3 contracted, and 3 contracts through any legal team is an act of God, so I celebrate that one in under a year. Not only did we get them connected to us, but we also we started using our technology partner, which is Availity, because if you don't know, MCOs and payers in general aren't used to consuming things that aren't bills. So it's either you come in and on a fax, or you send us, it comes in on a fax, or you send us a bill, and that's pretty much it. So thank God for Availity, Katie. She taught me that you can do a whole lot more, and you can actually consume some of this data, and you can actually use it in other ways. So thanks to her portal and her connecting the HIEs to it instead of me, I can go in and get one report, and we can do automated distribution. We added behavioral health case managers in 2017, so now it goes to all the case management teams inside of Superior across the board, because we integrated with behavioral health in 175 different PCP groups. And then last year, we got our first chance to participate in an emergency. When Hurricane Harvey came through, we have our own PBM, so we know all the pharmacy claims at point of sale. Nobody else really has access to that information and is contributing it to an HIE, so I thought I'd give back. And we pulled the last 120 days of pharmacy claims for every member in the zip codes that were affected and gave them to the HIEs within a day, so that the doctors who were in the shelters could actually have access to that information. Because when people come in and try and explain what their meds are, they're so distraught they can't. On any given day, they most of the time can't. They carry around bottles of prescriptions. So doctors were able to reissue all the medications that were missing, which was really awesome. In 2018, we aligned with Availity to combine 5 data sources. So we have hospital files who send us ADTs to for our largest groups. And they put them all inside of into their provider portal. I can't talk anymore. Provider portal to give out provider notifications and case management. We're adding more, becoming more of a contributor. So we're giving out claims information. So it seems weird to give back a claim to someone who sent you a claim, but it isn't that simple. We give back all the claims of everything that happened to their member. So did he really go see the diabetes specialist? No. Now we know they didn't. Or yes, they did, but they didn't do an A1C because they can't find it in the chart. So it helps bring that continuum back and forth. So we provide that. We provide all the pharmacy claims as well. So we've worked on contributing. The alerts are up to 1,000 PCPs get an alert every day. We're working on collecting CCDs from other HIEs, and then contracting with large EHR vendors that are EHR-specific vendors to collect CCDs directly when an encounter is closed. If you go into the doctor and the minute it's signed off on by the doctor, the record comes directly to us. It'll go through Availity, and then they'll share it with us. So value-based care. Why does an MCO want to play in an HIE space? Why do we want to get information from Sequoia Project, or eHealth Exchange, from all the national ones? We believe that the more information that we can give out and the more information that we can get back, All of us understand patients better. All of us can help patients better. And we want to think about the member's experience or the patient's experience. The patient is experiencing repeated tests. This patient is experiencing stressful, encounters and going through things that they shouldn't have to go through because no one can help them when they don't know all the information. So for value-based, we're working on risk-sharing contracts. At the moment, we're doing shared savings contracts. So we have a couple that are risk-sharing, but mainly the idea is if they're going to share risk with us, we're going to have to give them a budget to work with. So we use risk adjustment information out of clinical data and take it and create this risk score and a budget for it. And as much care as they can provide within that budget, if they save any of it, depending on their quality scores, we give them that portion back. They can get up to half of that money back. But they can't if they don't know what's happening to their members. So it's important that we sign data exchange agreements with them. It's built into our contracts so that they have to give us data back. And now the next step is to get them to give it back in a format that's much more usable to us. And then we're, data funding, yes. And then we've even actually gone so far as to take some of our larger groups and pay for them to connect to HIEs. All right, so I know the DRSA always leans toward other directions, and they look at MCOs and go, you just want to deny payment. I'm like, we really, really don't just want to deny payment. We are not going to pull a medical record just to deny payment. We are going to pull a medical record so that we can improve care and improve what everybody else is able to do for patients. So HIE increases our ability to improve health outcomes by being able to design interventions for members with more complete and timely data. Our care management teams use it to identify high-risk members to enroll them in specialized case management programs. They notify care managers when a member's been admitted to a hospital or an emergency room. They can facilitate discharge plans upon admission, and that's really key. If we don't know they're there, we can't help them. Once they're out, they're gone. We can no longer find them. We inform case managers of the case management teams can inform everyone in the care plan what services need to be done so that they can help schedule it. So we're pushing care gaps as well. All right, for operations is going to be, federal law requires that MCOs develop a written quality strategy, including quality metrics for reporting. States and their contracted health plans use these strategies to assess the quality of care that beneficiaries receive and set measurable goals for targets and improvement. So yeah, we have to do that. We have to measure quality. We have to set benchmarks. We're measured for accreditation by HEDIS, with HEDIS and NCQA, for quality improvement programs such as STARS, and then for risk adjustment so that we can do the provider incentive contracts. And most of all, we really want the data to reduce the inefficient and duplicative chart chasing activities costing both the MCOs and the providers excess time and money. One of the key things that we started this project with was to reduce provider abrasion. Is they hate payers because we come in and go, can we have 1,000 records like tomorrow? And so if we don't have that, if we don't have to do that and we can get it electronically, it saves everyone. For emergency treatment, I talked about this during flooding. We can help provide that information, not only to give them the prescribers, not only to talk about their prescriptions, but to tell the physician who's caring for them in the emergency, but who their PCP is and who their most recent prescribers were, so that they can coordinate their care and then send those records back when they give that patient back. Whoops. All right, so what's next? You guys have obviously heard of Pulse. We want to bring Pulse to Texas. We want to expand ADT alerts and CCD access to additional PCPs and care teams, external care teams like nursing facilities, like home health agencies. We want to enhance data sharing to HIEs to share back with everyone and directly to providers. And then we want to automate the authorizations for hospitals for some services. So for any inpatient service that patients come in for, we get a request from the hospital that says, hey, can we do this? Can we have this service? Can this member stay? And we have to say yes or no. Well, that requires a nurse to pick up a fax, type the information in, open a case, decide, make a decision, and then send back an approval. Well, who's going to turn down a labor and delivery case? It's not going to happen. It's an automatic yes, no matter what. So if we can use ADT messages to facilitate that process, just in the first year alone, we can save about 22 full-time employees. And that helps hospitals too, because they're not doing the same thing. We want to push member care gaps to PCPs for preventative care, like reminding them to do mammograms, reminding them to do annual exams for pap smears, all of the across the board preventative care tasks, and then chronic case management tasks. And then notifications to, a new one is actually notifications to a PCP when foster care kids are taken back into DFPS. So Superior takes care of every foster kid in Texas. We're the only MCO that has that contract. And so we want to be able to notify a doctor, hey, this kid has been moved from this foster site to this foster site or back into the DFPS system. And finally, our goal for being here and participating with this is we really want to connect to the national HIEs using our clinical data exchange partner, Availity, to bilaterally exchange all clinical critical data. Thank you.
So you can tell we've got the best of all interoperability here. We're fortunate enough that we have private and HIEs and community HIEs. We're using all of the possible use cases, right? Treatment, payment, authorization from the patient, operations. So we're fortunate to have this esteemed panel here that can help us. We want to open it up for questions because I'm sure you have questions, but since I have the microphone, I guess I get to go first. Let me ask the panel, and I'm hoping, do we have a microphone, or can we, maybe we could, do we have microphones? Okay, excellent. Tell me from your own perspective, what is driving the demand for increased interoperability?
Payment?
Tara, yeah, I can hear you. Yeah, it works.
Probably payment, the way you know that payers are restructuring and the way that folks have to be reimbursed is certainly a driver. But I also think that we've gotten pretty good at what we do. I mean, wouldn't you say we've gotten pretty good at what we do? Mm-hmm. And I think that providers are hearing about HIEs and they're hearing success stories out of HIEs, and that's driving demand as well.
Mm-hmm, mm-hmm. How about you, Matt? Anything else to add to that?
Sure. So, for
Not to put you on the spot.
no, payment is a key driver. For us, the providers have always been the big driver. They really need the data that they need to take best care of their patient, mm-hmm. particularly in our hospital and our emergency departments. And they've really gotten used to that as the standard. Mm-hmm. And actually, in our community, and we're in Silicon Valley, patients are now, they've had a hard time with ROI. They don't want to go to 15 different places. And actually, particularly where we are, and Stephen Lane left, but we're right next to Sutter, we're right next to KP, 40% of our bone marrow transplants are KP. The patients are now expecting that information's in the record. And if the doctor doesn't know it, they're telling the doctor, go look at this screen because I know it's there. Mm-hmm. And why isn't it there? And why didn't, because they don't want the faxes. So, patient experience is now becoming a driver for that. I think it's going to drive selection, obviously. Provider experience is critical so that they can make the best decisions with the most important information. And then it comes down to value in terms of gap closure, reduction of unnecessary testing, better diagnoses, all of those things. So I think those are the three main drivers. Oh, and quality. Quality and reporting,
let's
too.
Let's not forget quality. And I want to expand a little bit more on the payment side. And Tracy, I wonder if you could help us. You talked a little bit about the value-based reimbursement contract. And right now, I think I heard you, payers are accepting more and more, especially MCOs, risk. But I think it's starting to go to providers as well. Can you help us understand
Sure.
What are you all interested in for interoperability?
So the way that it works at the moment is pay for performance is kind of how we started. And so the more that we can tell them about their patients, the more they can save money, which works all the way down to us, right? So we want, when they do shared savings contracts, they save half the money back. If they have risk, then they save less It's more about they get punitive damages if they aren't able to save it all. But if we don't have that information, if we can't see what happened to this patient, anywhere else, because think about Medicaid, right? Members come on and off every single month. They can change MCOs every single month. And all of a sudden, we don't know anything about this person, and they're brand new. Same thing happens to providers. They get a brand new patient every month, and they go, we have no idea who this person is. How do we decide what that risk score should be? How do we decide what the budget for that person should be? So if we're able to go retrieve that data and be able to put it together and hand it to a doctor and say, here is all the things that anyone in this area knows about this patient, then we'll have more accurate scores, and that'll help providers be able to make more money back and help MCOs be able to continue to take care of the members the way that we want to.
And certainly we have the MCOs and the Medicaid risk, but then the Medicare Advantage also has an opportunity. Matt, how much is the risk being pushed to providers now? Are you seeing more and more commercial Medicare Advantage and Medicaid asking you to participate in that risk sharing?
Well, yeah. When Stanford actually, we run a variety of different health plans and accountable care organizations. We've been focusing on our population health management strategy, both at the team level in the primary care clinics and giving them the tools that they need, as well on our health plan side. We're mining HIE data to fill in those care gaps as much as possible. We're doing that every which way we can, and we're trying to get engaged. It's wasn't always our strength as an academic medical center, but it's becoming a key driver for us too.
And Matt, I just want to go ahead and give it to Stefan, because you mentioned the patient and the patient's demanding more. So your use case is truly for the patient. Stefan, can you kind of tell us more of the value of this life insurance?
Yeah, absolutely. No, I think that's right. It is very patient oriented. There's, the concept, you apply for life insurance, you fill out a ton of forms, you just sign your name everywhere they say sign here, but among those forms, and all those forms are, of course, submitted to and approved by the state government in each state, the state insurance commissioner, is that HIPAA authorization form. And so there's that simplicity that, hey, I completed all my paperwork, life insurer, you go do what you need to do to get me a price and a quote so I can buy the policy that I want. And this makes it pretty simple and straightforward. There's that opportunity that the patient can just kind of sit back, wait for the life insurer to come back with their findings, and kind of go from there. Whereas the current process, it could take anywhere from 2 weeks to, our CEO actually just went through this, and I think his policy took like 12 weeks to get placed. There's a ton of waiting time. Consumers can drop out of that process. This just makes that a whole lot simpler. And for life insurers too, there's, on their side of the equation, I think one of the common threads across all the use cases we talked about is this concept that we can take all these resources that are dedicated to chart chasing and administrative activities and start turning those into more value add focused types of things and providing more value for patients than we can today because we're so busy doing all the simple, mundane administrative work.
And I have to share with you, when we brought that to our board for this new use case for UHIN, we were very fortunate that our chairman of the board had just applied for life insurance and had gone through that nightmare.
Timing.
Yeah, it was perfect timing. How about you all? Do you have questions for the panel? John? Oh. John, you first, and we'll come over here.
Matt, if I understood your presentation, you have a high-volume exchange partner with Dignity.
Correct.
Stanford is Epic, Dignity is not.
Correct.
Can you talk a little bit more about, is that done under Carriage Quality? Does it use eHealth Exchange?
So it was started through, it's eHealth Exchange. They're actually, and we've been through multiple iterations with Dignity, and Stephen Lane left, but we actually now have this consortium in the Northern California area with a bunch of us on the Dignity side, the folks from a lot of the Epic sites in the Northern California region, Commonwealth, Cerner, we were all participating. And we're getting into the nitty-gritty, like, somebody said the docs want the notes. Mm-hmm. We had a real hard time exchanging notes between the Cerner system and the Epic system, the difference. And Dignity actually has been on multiple gateways. They were originally on their own independent gateway, and then they moved over to a new Cerner gateway. And we've learned a ton working with them. when we reached out, and it's just been a great working relationship. I think both of the vendors are learning a lot, we're learning a lot. It's an eHealth exchange, that's our ticket to ride. We've been able to push the limits as much as possible and do a lot of really nitty-gritty testing with them about making sure that their docs can see notes and our docs can see notes, that we can query between encounters and make sure that that's all auto-query works very, very well. And we're trying to work through that in a way that we think is scalable, hopefully, for the rest of the country. So that's been our experience. It's been a very positive experience. We just share a ton of patients with them, too. So Sequoia Hospital is a dignity center, and it's, 5 miles north of where we are. It's right in that Redwood City where our ambulatory site is. We have a ton of ambulatory practices in the Santa Cruz area, and then big hospitals in San Francisco. So it's been great. They're really an incredible resource, and I think just to sort of add, one of the comments I do want to make is there's an amazing amount of work going on and incredible resource in this room. And as John mentioned, the more you get involved, the more you'll learn.
Tara, do you want to add, because you talked about bringing all those different EHRs together as well, and then I heard you set up connections through eHealth Exchange so quickly.
Right. And we have Epic and Cerner integrations as well. And they work really well, actually, pretty seamless on both sides of the equation there. And through eHealth Exchange, there are, a smattering of different vendors represented by folks on eHealth Exchange. I find that when you are sticking to the standard, which y'all gathered that's not my favorite, things are pretty easy. We almost always go back, especially if it's an eHealth connection that we've had to stand up quickly. We almost always circle back and say, okay, we did this, we're stable, how can we improve it? What else can we share? Let's add, we want to send you all the data we have. What do you have access to? So you stand them up quickly because people's lives could potentially be at risk, but then always circle back and always ask the question. You will be surprised at how many vendors think, I'm not going to tell you they'll do it for free, but they have the ability to send you notes, which is going to drive your clinician satisfaction.
Thank you. Question over here.
Ed Cortez from Manifest Medics in California.
Excellent.
Any thoughts or advice in terms of monitoring, measuring the value of interoperability? Right now, people are looking at messages like, send and receive, access, but any advice in general?
Measuring success of interoperability.
Okay, well, that's a simple one, right? Most of us started just with links and then CCD transfer. Now we're looking at view, utilization, reconciliation rates. They're all process pieces. Ultimately it's going to come back to, I think, the total cost of care for any given beneficiary in a year, and a way that we're starting to see some data about specifically, at least in the delivery space, reduction of unnecessary duplicate testing, whether it be labs, complex imaging, unnecessary admissions because people have access to the information that happened yesterday. But until we can look at it at a patient's total cost of care at a beneficiary level, and then kind of dig in, and we're working on trying to figure this out at the clinician level. Did seeing that information change the way you manage that patient in that encounter? Not easy to do, but we're starting to play around with that. There's actually a very exciting little pilot study, I think, going on in San Diego, where in the ED, they're going to do just that. As part of their discharge process, they're going to ask the provider to give survey information about, did you see it, did you look at it, and did it actually change your decision-making or change your ordering patterns? Until we have that kind of data, it's going to be really hard to measure that, but ultimately it's going to come down to what we're paying for the cost of us to get health care.
And I would say never underestimate the power of a story. I mean, what Tracy did was very powerful. We measure utilization, and providers who are we have about 20 providers who average 600 or more queries a month, and we call them and say, why do you there's a reason you keep clicking the button, right? So why? And we learn all kinds of things. So never underestimate the power of not only a patient story, but a clinician story, because he can say, if he has trust in it and this is why he uses it, that speaks to other clinicians.
Yeah, we do while life insurance, this use case sounds very transactional relative to a lot of the other things being discussed up here, we actually, every individual life insurance company we work with want to prove out the ROI within their business processes. And so we'll do, really small trials, maybe 100, 200 cases, but even with just that small sample, can start to get at some really meaningful data. And the important things we found were, track decisions that are made at various multiple points in the process. So we have people underwrite the same case multiple times using different combinations of requirements. And then for each of those cases, track multiple outcome measures to say, how does this impact cost? How does this impact timelines? It's really, really labor intensive, but find that even within a small sample, you can start to tell those stories about exactly what the ROI is and what percentage of cases, each value driver impacts, and so on. It's set up a lot like a comparative effectiveness study would be on the healthcare side, just with different types of data and proof points and outcomes and so on.
I heard a lot about costs too. Tracy, do you want to talk about what you're measuring for success on your side?
So it's twofold. Is this on? We survey our providers and make sure that, we ask them, do you use it? Why do you use it? What success stories have you had from it? What difference does it make? What would you like to see next? And most of them have come back with things like 50% of the time we can get patients to actually come in for a follow-up. Can y'all hear me okay?
That helps when she helps.
Okay. Change it. So they'll say 50% of the time they could get a member in because they had new demographics. They told, the patient told the hospital their accurate phone number this month, and they're able to call that member and actually get them in, even if they've never been able to find them and never gotten them into their practice before. So we do it from that point of view, but then at the same time, when I have to justify why am I paying an HIE as a payer, you want to know how to market to payers? Is that where you're going with that? The magic is in numbers, right? You heard me say that I can save 22 FTEs. So 22 nurses are not physically entering in a faxed sheet of paper to create an authorization that is going to be auto-approved anyway. So efficiencies like that. You're from Manifest in California? Ooh, I'm trying to teach my team how to negotiate with you. Can I really give you the secrets?
Step one, right there.
So I'm probably not the best person for No. We originally started with a really low pilot price because it was a new project and all we were getting was ADT information, and the HIE that we started with had only one other payer, and they weren't really sure where to start. But since we have the volume, we did a tiered scale so that we could say, okay, if we give you 100,000 members, you'll charge us this much PM to monitor those people. Doesn't matter if they have any transactions or not, you're continuously monitoring those people. So they get a new file every month of all of our eligible members, and they just scour, and when they get a hit, they send it to us. Now on the flip side, we measure you back. What we do is we go 90 days out and we take claims reports. And so we know what services were provided, right? Let's find out how many times you told us that they were provided. And so when we first started it, we had to work on our matching tremendously. And we've gotten it on our own. We had it at 40%. So 40% of the time, somebody would go in an ER and I hear about it. 60% it didn't. So partnering with external people who actually know how to do this stuff and actually can do it on a much more massive scale and have the tech back for it, because I'm a nurse, I learned how to be an informaticist, but I didn't learn all of the tech behind, let me code every single connection. I worked with the HIE to do it, but when we needed that volume and scale, we ended up partnering with Availity, and so Availity is the one that handles the matching for us now. So now we went from 40% to 94%, and so there's just a couple of newborn babies that are filed in Medicaid. They're filed under their mom's name, and so you can't really match those very well. So I'm thrilled with 40 to 94%. So yeah, it goes both ways. You can measure in any direction.
Other questions? Yes.
Hi, Jamie Ferguson from Kaiser Permanente. So there's been obviously a lot of success on the exchange, but there are also still gaps. And a lot of the gaps that we hear about are with independent physicians, small practices, and independent don't have the resources to have, and the support to have the same kind of connectivity. And so what we hear is that their problem with interoperability comes back to the business case and having a business model that makes the connectivity make sense for them financially. And that then necessarily involves the non-treatment use cases. So they have to integrate the non-treatment exchange of data in order to have a business model that makes sense. But the DRSA prohibits or inhibits some of those non-treatment use cases. And so we're seeing a growth of these alternative arrangements that makes the growth of exchange actually off eHealth exchange. So, what do you have to say about the, those, that sort of that dynamic, and how can we drive more of that volume to the eHealth exchange?
I don't know how,
Teresa, I may be able to take a first stab at that.
We like it, Jay. I was looking for Steve, but
Yeah, so the good news is that our proposed revision of the DRSA, which we hope will be adopted very, very soon, does take care of those ambiguities and makes it will make it much easier for a superior Centene, as an example, to join and be able to query for treatment, operations, and even payment.
Tara, did you want to add to that?
just, you're right, this one does not work. So Jay answered that part beautifully. I will say we're located in a very rural area and a lot of one-doc shops and a lot of critical access hospitals. Even when they bought in and said, you're right, this would be awesome, money is a factor. What we've been able to do is to go to vendors and, I don't want to call vendor names, sorry, and say, hey, you small hospital provider, we have 15 hospitals in our state. We want to group buy. We want to group rate. And we found really good luck with that. And whenever we have had made over our revenue, we actually would offset the cost of what a hospital would have to pay for the vendor on their side. But sometimes just by getting a group buy and lowering the cost, and the hospitals would know that they're doing this with their other peers and they weren't the lone one, we found great success in that. I don't know if that was helpful, but.
Yeah, I was going to say, and we've had a little bit of luck with getting people connected to something like the Social Security Administration use case, where we can use those transaction fees to offset the costs that we charge to our own HIE participants, so that we can at least get them on board. When they connect to us, they also get on board with eHealth Exchange. It opens up connections to some of the federal agencies. And typically, that value proposition works out pretty well as a starting point. So finding good partners in the region, I think, like it sounds like Gracie is as well, who can help provide some of that support and figure out other ways of getting everybody working together, but at a price that actually works for people. We like to do a lot of the, and even for like the more advanced healthcare providers, a lot of this connectivity work, stop spending so much time and attention necessarily on like the basics. We'll take that off of your plate. We'll manage all of that. And then you focus on the real value add stuff, develop specific programs with your closest payer partners and so on, as opposed to the connectivity.
And I would add that we worked closely with our state to get some grants. And as we request grants for a particular use case, we've set aside a portion of that grant money for what we call connection grants. And that helps mitigate the cost, because it is costly for those small hospitals to connect and ambulatory practices, and that helps mitigate some of that cost. I saw a question over here.
When we look at payments to providers from payers or anybody to help connect up to health information exchange, how many are actually paying for connection to something like eHealth Exchange versus the individual interface types, the ORUs, the ADTs, the MDM interfaces? One of the things that I struggle with is by the end of this year, I'll be connected to probably 22 separate HIEs across the country. Those 22 HIEs have to
insurers that want information. We've got other groups want information. One connection to eHealth Exchange, they can connect to anybody they need to query for information to get because it's critical.
So I might, great point. So later this afternoon, we are going to be announcing a solution that I think will satisfy that concern. And Margaret Donahue is going to kind of touch on it a bit. So stay tuned until later.
Something to look forward to. Kevin?
It's Kevin Larson from CMS. I'll just mention, and most of you likely know this, but although meaningful use is largely done, there's actually still a few $1 billion in Medicaid waiting for your matching requests from your state Medicaid agencies. 90-10 matching money, a lot of it aimed at interoperability connections. So if you work through your state Medicaid agencies and your state Medicaid medical directors, they have access to that matching funds through 2021 if you can get match from your state. I know in many states that's the trick is trying to get the match from the state, but that exists. There's even been a medical director letter that allows for those matching funds to be non-eligible providers, so we can connect to behavioral health and home health and other people that weren't eligible for the meaningful use program. So just to let you know, that money's still there. It's our money. It's waiting.
I think one of the problems there is the 90% match money is being drawn down in many states. It's being drawn down specifically connecting to specific individual HIEs, not being given up to look at legal costs, implementation costs at the provider level, who might wish to join something like eHealth Exchange. And so they're actually being thrown out of the program and don't get access to that money to be able to, they're the ones pulling that money down in many cases and don't have access to that money.
Yeah, I think it is important that it's one of the things our state has been very good about is working closely with us so we could have that money for our providers to be able to draw down. And we have very unique cases where MCOs have come up with the 10% because they are trying to mitigate that risk. And we've got a new use case that we're trying to stand up, which is called fall risk and identifying potential fall risk patients.
Yeah, a number of states have used MCOs as the 10% supplier for the matching funds.
Yeah.
We would be thrilled to pay 10%. We pay 100%.
Yeah, yeah.
So work with your state manager office.
Yeah, in Texas, they're not really.
I saw a comment over here.
Yeah, Dan Paladium with Ohio Information Partnership. I have a question, a comment. I haven't seen the new NERSA, but my concern with use of data outside of treatment, it's the same issue we had with TEFCA that we never got a response on, is the provider responsibility and the patient rate when deemed necessary. And it's very difficult. We have not, even with some of our most sophisticated hospitals, so we have some pretty sophisticated, we do not have the ability to respond to minimum necessary requests for a payment use case. And so I want to throw that out there because I still have a lot of concern and everything that we threw out, all the questions we threw out to CMS and HHS around TEFCA, the response we got back was, yes, it's still a direct responsibility. It doesn't help because technically it's not there. So just a comment. My question is actually kind of two-part. One, when you're bringing data back in through eHealth Exchange or care quality or whatever connectivity, what's your biggest problem with using the data? First question. So one of the things that we spend a tremendous amount of time on is the actual usability of the data at the bedside. So I'd be interested in feedback on that. But Matt, my other question for you specifically is your chart as far as the numbers you threw out around Exchange was pretty amazing. I noticed the HISP numbers were big but small in comparison to everything else. I'd just be interested in the use case of push, because everything we're talking about is full for the most part. And we see a lot of use cases around push capabilities as well. So sorry, I threw a lot out there, but
Yeah, let's see where to start. So the HISP numbers are small partly because we have other methods to cache and use direct messaging. So we are pushing, although it's still a very small amount relative to our query for treatment for that pop. I mean, we're doing some push related to, standard promoting interoperability, discharge information from ED, hospital, all of our referral management. We're doing a lot of that. We're caching a lot of our own direct messages because we can do that through our network, our vendor network, and we don't need the SureScripts HISP. That's just the SureScripts HISP. So there's a lot of other direct traffic going around. I think what you're also saying is sort of getting back into what Paul's saying is everybody wants an ADT ORU as well, and we're trying to push them back to just query us. Just get in the eHealth Exchange, query us, get the data that way. Don't make us make all these, redirect our ADT to 4,000 people. We don't want to do that. That's actually a problem. The relevance issue has not been solved, right? The systems have to get better. We have some interesting data. We know which doctors in which clinics look and where and why a little bit. The dermatologists want a photo. They don't want a CCD. We figured that out. That doesn't take very long. So we're now doing all sorts of, image exchange for those guys and image consult. But we're really, the systems have to get better at knowing that in advance and then bringing forward the components of the CCD that are most important for that clinical context in that visit with that provider. So we're starting to see, for example, specialty CCDs that we're really working on, whether it be for dialysis, renal transplant, OB, perinatal care, cancer care. But the systems they just need to get better, and we're trying to figure out how to leverage that. That doesn't mean there aren't opportunities. There's a ton of opportunities, and we know there are huge gaps there in terms of both relevance and readability, right? At least now we're starting to be able to bring that stuff in and basically chart search everything, internal, external, the whole shebang. That's starting to happen, so our providers are able to do that now, but there's lots of work to do. I don't know if I answered all your questions.
Yeah, I think that's meaningful use. All of the regulations were built towards specific use cases. And we didn't do a great job at making them meaningful. And so a NIST validated C32, my technical team will be so proud that I knew that word. It meets the requirement, but for a clinician, it's not very helpful, right? So that's why we really are outside of the standard. We also own eHealth Connection. You're still standing up point-to-point connections. And so we reach out to Jay and say, hey, Jay, who's the point of contact at X, Y, and Z? And we reach out, and we go through testing and validation. We don't just go through the UD and broadcast things to make sure that we are putting the ITI transaction where it's supposed to be and all that stuff. So there's still work that you have to do.
And I would add, even though a lot that we've talked about is a query, we've seen real success in that query happening automatically when the patient is registered or scheduled. So it's all in advance, in the background, and so it mitigates that physician burden quite a bit. With that, I think we're out of time. Is that true? I'm looking. Okay, very good. So please help me thank the panel we have.